Today I am going to discuss about the PCF calcified coronary arteries. As you all are aware, so the most important investigations for evaluating the coronary calcium, a traditional method, angiogram, is not very sensitive. So it detects the calcium in only 40% of the patients. Sometimes patient may have a moderate to severe calcium, but you may miss on angiography. The sensitivity of this OCT and IVUS almost is up to 70%. So that's the reason always in some cases you may have a problem in detecting the calcium. So what are the challenges of the calcium? As already highlighted by many speakers. So if you don't properly prepare the calcium, what happens, stent may dislodge, it may distortion of the stent may be there, and with high pressure it may lead to perforation and intramural hematomas and dissections. All these are possibilities. So that's the reason if you don't prepare bed, if you implant the calcium with unprepared bed, most of the time what it lead to a severe under expansion that may lead to a stent thrombosis and future restenosis. So that's the reason always prepare the bed well before implanting the stent. As per the acuity and heterogeneous trials, as the severity of the calcium increases, definitely the MACE rate increases. And it's not, see, if you see the incidence of the calcium in NSTEMI and STEMI patients, moderate is about 30% and severe is about 5 to 6%. So it's very common, but don't neglect. So if you see any particular advanced age patient or CKD patient is there, post-CABG patients always suspect the calcium even if the angiogram is normal, if it is mild. But post-CKD patients or patients with post-CABG patients or advanced age patients always suspect the calcium. So always assess the calcium before proceeding to any angioplasty. Is it mild, moderate or severe? And once you decide whether this patient, that patient is going to require any plaque modification is there or not. If you are doing the plaque modification, is that plaque modification is adequate or not? So if you don't do adequate plaque modification, that plaque modification method is not that much useful. So whatever you do optimally so that the results will be better. So when you see the OCT, you can assess the plaque morphology very clearly. Is it, you classify, is it lipid plaque, is fibrolipid or fibrocalcific or calcific. If the calcific, you can also assess the calcium expansion index. You see the almost circumferential calcium, and even in ISR lesions you can decide, is it neoarthrosis with calcium or is it under expansion with paraatherosclerosis. These things you have to distinguish. So reading is the understanding, the analysis very, very important. IVUS shows the calcium very easily like a bright white arc, but beneath that, because the IVUS rays will not traverse the calcium, so you may see shadow. It is difficult to assess the thickness. Whereas the OCT can show the thickness, but the problems of the OCT in a large lipid plaque, it may miss. So another thing is, if it is, you can assess the thickness, you can assess the length, you can assess the arc. You classify the calcium based upon the IVUS or OCT, whether the calcium nodule is there, what is the length, is it more than 5 mm, and what is the vessel size, and is there any calcium nodule. Based upon that, classify, and that is useful to assess the plaque modification devices. So we have always what type of calcium is there. It's very important to assess, because is it spotty calcium, is it concentric or circumferential or sheet shape. What we are more interested is a calcium more than 270 degrees, a depth more than 0.5 mm, a length more than 5 mm. Definitely expansion, the induction is more, so you have to adequately modify, otherwise it will not expand. So traditional balloon-based technologies are there. As you are aware, Rota, Orbital, lithotripsy, ELCA, these are all tools which are available for plaque modification. If you have an uncrossable lesion, you have two options. One is Rota, another one is a laser. But even orbital atherectomy also very useful. We have seen, we did the recently left main ostial lesions, uncrossable lesions, even LED lesions. This is also very useful tool when uncrossable lesion, particularly if you are able to paste the Viper wire or Rota wire. And crossable lesions, you have different options. But if you are able to cross fractures so that the future MACE rate is going to come down, that is very important. But the only thing, one exemption in IVL, when you use the IVL, you may not see the calcium fracture in all patients. If you see the DISRAP study, it is seen in only 67% of the patient. Remaining persons, when they also did some micro CT analysis of the autopsy studies, which showed micro fractures. It alters the complaints. So absence of the calcium fracture will not preclude to implant the stent. So that is the reason always in IVL patients, it alters the complaints of the. So you give the pulses adequately, subsequently implant the stents. So IVL is the simple balloon-based technology. It produces the microbubbles which expands and collapse and produces the 50 atmosphere pressures so that the microfractures and balloon is inflated only at 4 atmosphere. The balloon-based injury dissection is very less likely. Advantage, no need to lose the side branch wide. You can keep the side branch when you are doing the bifurcation stenting. These are the advantages. Slow flow, no flow is very low. Dissection is very low. The complication rate is very low compared to rota and orbital atherectomy. So that's the reason this is a preferred when patient is having ACS with advanced age, calcium nodules, thrombotic burden, unstable patients. So rota ablation or orbital atherectomy is preferred over IVL when there are severely calcified lesions, uncrossable lesions, and long calcified segment lesions. Why long segment lesions? Because IVL you have to use more balloons. Whereas rota or the atherectomy, only one device, so it will be a very cost-effective device. And as you already highlighted, rota and orbital atherectomy, one thing I can say, the orbital atherectomy, I feel much more safer compared to the rota. Why? Because it has a forward cutting and backward cutting, and because it also allows the forward flow while doing the ablation, so that the slow flow, no flow is less. Additionally, the microparticle production by the orbital atherectomy is only 2 micrometers, whereas rota can produce 7 to 10 microns. So debris is very small, so that is the reason the slow flow, no flow are less likely with orbital atherectomy. And whenever you do any PCI, always assess before procedure, assess the calcium. Is it in the, suppose if your bifurcation is there, what is the proximal LM, left main, what is the assessment calcium burden and luminal areas, LED also assess, LCX also, various levels. Based upon the why it is very important, one is selecting the device size, that is diameter, length, and at the same time landing zones. Are you going to land in a proper landing zone? That is very, very important. Once you do the procedure, you see that is it adequately expanded or not, any malopation is there or not, and any significant medial edge dissections. So always confirm that the medial edge dissections are there. So I think with this note, there are many slides, but I think if time permits, I'll show one case. You can see a very tight left main stenosis and RC, a very diffuse disease, osteal lesion, diffuse long lesion, and you can see the osteal left main, LED diffuse long lesion. You can see that this patient we have taken for rota, but you can see initially we crossed the LCX and we did the balloon dilatation, then subsequently distal LCX was dilated with a magic touch balloon. You see the dog bone effect. This case illustrates all the issues about the calcium. So this is the dog bone. When you find the dog bone, then you can see magic touch balloon for the distal LCX, and then microcatheter. We are exchanging the rota wire, and then this is the rota ablation, then slow flow. Then you can see the ST elevation. Then you can see the distally we are giving all nitroprusside, NTG, Nucaran, and you can see the I was showing the thick calcifilac more than 270 degrees. And you can see the very LMCA, and then subsequently plug burden assessment where it is. Then again multiple dilatations, post-rota dilatations, distal LED, and proximal to mid LED. Again guideline assist followed by 2.5 to 33 mm stent proximal to mid LED, and assessment of the proximal segment and left main to. We did the angiosculp, mainly prepared the osteal LM for adequate expansion. In addition to the rota, and scoring of the osteal LM 3.5 to 15 angiosculp, and then this is the positioning of the LM stent. based upon the multiple views, and 3.5 to 38 mm stent, mid-LAD, again post-dilatation, part of the left main, and ostial flaring, and this is the assessment of the post-stenting assessment. Distally still there is a plaque burden. So then because the plaque burden, then what we did again, balloon-assisted crossing. So when you cross the LMC stent, always do the balloon-assisted stenting. If you don't do, what happen, it may lead to LSD. Sometimes the stent deformation may take place. And again, Tajuna, Gaidjila, then 2.25 m distal stenting and post-dilatation. And this is the final angiograph view. I will go the distal dissection. This is the final. I will come to the final angio. This is the final result. So even if it is complex, you can tackle very nicely if you plan properly with adequate plaque modification, and definitely the IVAS definitely it's going to be very helpful. Thank you one and all for paying attention.
Thank you, Dr.
I hope you are all having a nice time in Hyderabad in HICC. I am very happy to so much crowd before NIC data presentation. Thank you one and all for paying attention.
Thank you, Dr. Sridhar.